Thank you, Mr. Chairman. It's a great honor to present my way of thinking. First of all, I'm not AI, artificial intelligence, but I'm a human. So I have several different points of view that can be maybe some the different day by day, but still I think it's very useful, important to understand what's the real situation of the patient rather than what is the current slide in my view. So pathology of cardiac transplantation is not limited to allograft pathology, but also it's explant recipient heart is sometimes very important for our reading of allograft biopsy, and also pathology of a donor heart, not limited to the heart, is also important. So, for example, the pathology of explant recipient heart is in every center. Cardiomyopathy and ischemic heart disease are two major groups, and congenital heart disease is a major group for children. Others may be retransplantation, valvular heart disease, and others. Recently, I experienced several examples of eosinophilic myocarditis, and also there are several reports that eosinophilic myocarditis is very common in transplant heart. It's very unusual for autopsy compared to the autopsy series that eosinophilic hypersensitivity myocarditis is a common incidental finding, although the clinical diagnosis was just a DCMP, but the pathologic diagnosis changed it to eosinophilic myocarditis. Some report says it's an instance of eosinophilic myocarditis among DCMP is 7% or 22%. Even 7% is very high. And also there are some interpretation that possible relation of hypersensitivity reaction to some inotropic drug before the final transplantation can be the reason why we have eosinophilic myocarditis, not because it's the original cause of the heart failure, but it's a process after it became failed. And also pathology related to VAD is also important when the patient received the VAD treatment before the transplantation. And also it must be considered that some disease are recurrent, make a recurrent cardiac lesion after transplantation. Common examples are amyloidosis, giant cell myocarditis, sarcoidosis, and other conditions may manifest in the heart after transplantation, transplanted heart. So it must be considered what was original diagnosis was the patient before the transplantation. The pathology of donor heart is also important that the donor heart pathology is different from the recipient explant heart. The donor heart is the best donor heart is completely normal, good heart, good functioning recent heart, fresh heart, but it's not the real case. So sometimes bicuspidal valve can be in the donor heart, and also donor may have cytomegaloviral infection, toxoplasma, and hepatitis, and so on. So also the donor heart may have some hidden malignant condition in the body, and also prior to donor after brain death, before the procurement of the heart, the ischemic injury of the heart is very common, sometimes unavoidable. So because at the agonal stage, the catecholamine level can be higher than usual situation and hemodynamic deterioration and so on. So it may be the normal heart at the beginning, but when the explant and donor, it becomes donor heart, it can be some kind of abnormal heart, particular for ischemic change of the heart. And then pathology of the allograft heart is the real topic today. And also the pathology of allograft is not limited to pathology of rejection. other conditions also may complicate and manifest in the endomyocardial biopsy in those situations. So infection is one of the most important conditions that has to be excluded from the beginning. And also perioperative ischemic injury is very common and very important consideration when we interpret the allograft. Of course, the acute cellular rejection and antibody-mediated rejection and QT effect are three major conditions we have to be interpreted and consistently to make clinical management most optimal to the care of patient. It is very stable condition that the cardiac biopsy after transplantation has been very stable for acute cellular rejection. Original classification is like this, and the modified revised classification is used from 2004, and it is grade 0R, but as you can see here, it's just a grouping of the original classification. So if we write 3A, that is exactly equal to the 2R. So for example, I personally still use the original classification so that the clinician can say that if I say just 1R, it may be 2 from the original classification or 1A from original classification. So I think it's better for clinician to describe the original classification. Yeah, this is the example of the endomyocardial biopsy interpretation. This severe examples we never see this severe example in the usual situation, but there are certain caveats to find the correct decision of these 4 groups. And also one important thing is that how is the usual situation for acute cellular rejection instance in the global or local situation? And it's very good to have this kind of a chart to understand how open the rejection is, and so that I can control myself for my interpretation to see this. One important and constant trend is that incidence of rejection becoming very low recently. So it's less than 2 or 3%, but it can be, yeah, this chart is very simple, but rejection per biopsy can be 2% or 1%, but rejection per patient is higher, of course. Because we have 5 or 10 times biopsy in a single patient, one of them may have a rejection in that. So that's the story. So we have to control our interpretation to this group that 1% or 2% would be appropriate decision. If it is too high or too low, that there may be some problem in my interpretation. But let's think about that. What's the rationale of surveillance of acute rejection by biopsy? One thing is that we understand, and it's scientifically correct, that cellular rejection starts from perivascular lymphocytic infiltration. We all agree. The second thing is that loss of myocyte start from necrosis of myocyte, not from the lymphocytic infiltration itself. That means just a lymphocytic infiltration is not good, but it's not very harmful for the myocardium. So we have to differentiate whether the myocardium is combined with necrosis in addition to perivascular lymphocytic infiltration is the key issue for this thing. So what is the necrosis of lymphocyte? So in this case, I can interpret these 2 pieces necrotic myocardium. It is not different from the H&E section, but it has a less strict the cross situation is vague and so on. And in this case, there looks like something in this area, but there is nothing, just the inflammation. But we interpret this as there was a myocyte here, but it's disappeared and become necrotized. So we think these two occasions saying that there's a necrosis of myocardium. Whether the necrotic debris can be seen or not seen. And the third is that the damage to myocardium is a diffuse process in right ventricle and left ventricle. That means that we are biopsying right ventricle, but we are keen for the condition in the left ventricle. Through biopsying right ventricle, we think it's similar in the left ventricle. It is true, but it is also false. What I mean true is that at the macroscopic level, the scattered necrosis has to be global in the heart, right or left ventricle. But at the microscopic level, it's not that level. So if we have only one small piece of myocardium, it may not represent the whole myocardium. That's the reason why pathologists ask the clinician to give some more piece of myocardium so that we can have a better correlation to the whole myocardium. And damage to myocyte is not accompanied by detectable clinical symptoms or sign. I mean that if there is a good clinical correlatable clinical symptom and sign rather than biopsy, that would be much better. But still, we think that biopsy pathology can be the most, the earliest condition we can detect rejection. Yes, it is true. Some patient with early acute cellular rejection has no clinical signs other than histopathology. That's the rationale for biopsy interpretation. But it is sometimes other has symptom and signs. So in that condition, we may rely upon the clinical condition in addition to biopsy pathology. The reverse is also true. So we have to communicate with clinician whether this is normal and abnormal, but we have to think about it may not be represented by the clinical symptoms. The fifth is that non-immunological damage, mostly ischemic damage, is also occurs in the myocardium, but it is possible to detect this non-immunologic damage from the immunologic damage like acute cellular rejection. And also local process like a previous biopsy site is also possible to monitor by pathology. For example, these two slides has some debris of eosinophilic something in the interstitium. I can interpret this ischemic myocardium, but it is not associated with lymphocytic infiltration and clinical sign and other pathologic hallmark of acute cellular rejection. So it's just an ischemic injury, perioperative or previous condition rather than recent ischemic injury. And this is a previous biopsy site. It is very well known that the catheter course is also usually follow the same course to the previous insert. So it's possible to see this kind of situation. But we have to understand this is a previous biopsy site rather than damaged myocardium. Yes, it's acute. It's a rejection or not. Most pathologists, even me, can say this is a rejection because there are marked cellular infiltration of lymphocyte and some abnormal necrotic-like myocardium in here. But if you see low power view, it became a kind of sharply demarcated. The rest of the myocardium is normal. If you look the wider field, we can interpret that, oh, this is not rejection. The rest of the myocardium has no evidence of rejection, no perivascular lymphocytic infiltration. So it can be a kind of curated region lesion rather than rejection. So going to high power is not always a good way to interpret it. Rather than we can see the whole environment and circumstance why we are dealing with this condition. Yes, this is another example of this and by CD3 staining, which is a T-cell marker, we can see it is only concentrated in this region, and the rest of the myocardium is almost free of CD3 lymphocytes. So it suggests acute lesion. And also, there are other definite areas of subendocardial acute lesion, so that we can say this patient may have several foci of acute lesion in this patient. Even wider view of this case will show that the lymphocyte is limited to subendocardium. So now we feel happy to tell this is not rejection, but it's acute lesion. So the overviewing the whole specimen is a very important step to do not any mistake to interpret it rejection and unnecessary treatment for this patient. Ischemic necrosis is very common in myocardium. So I use C4D staining for ischemic conditions. So you can see the brownish spots, many areas, and this is necrotic myocardium, but not associated with lymphocyte infiltration. By desmin staining, the same slide shows that there is no desmin positive myocyte in this zone where C4D staining is positive. So this desmin and C4D is negative and positive correlation to this case. And also sometimes this desmin loss can be detected by light microscope, H&E section. This is a necrotic myocardium, ischemic necrotic myocardium, not immunologic necrotic myocardium, can be detected by negative staining of desmin and also positive staining of C4D. This is very useful marker to find this condition. And by making a serial transplantation biopsy, we can see there were two instances of significant rejection in this patient. So we can review those history, and we don't know exactly what happened to this grade 3A condition, but there will be some reason that can be recognized or that cannot be recognized, but we will do it. And also, there are other examples that acute lesion is common in some patients, some other patients that do not have often acute lesion. So this is the personal variation of this. So by summarizing this first half of my talk, the amount of biopsy, 3 pieces or more, is better than 2 or less, in the sense that we can view the whole image of the left and right myocardium. And background myocardium is also very important for interpretation of a specific condition. And overview is the case rather than just viewing the small piece of myocardium is necessary to not to do mistake. And immunohistochemistry for CD3 and desmin are very useful. And also digital pathology and reviewing and comparing is very useful not to do any mistake for. And then the next part is graft allograft vasculopathy. And allograft vasculopathy is very famous for chronic rejection and chronically failing heart. And cardiac CAV lesion is a diffuse lesion, concentric lesion, But the atherosclerotic lesion is usually eccentric lesion, and there is a focal disease. And also, it's important the location of allograft vasculopathy is within the myocardium, intramyocardial vessels, but atherosclerosis is almost always limited to subepicardial vasculature. Yeah, there are the good photographs of this condition, but I'm sorry I don't have any experience of this condition because we have no history of replantation, the autopsy after transplanted death. So it's unfortunate, but I can review these cases. And also, it's not very certain that cardiac allograft vasculopathy is caused by acute antibody-mediated rejection. But in the review of examples, we can see the instance of AMR is more common than those not commoner in cardiac allograft failure and cardiac allograft vasculopathy. So we consider the repeated episode of AMR will cause the allograft vasculopathy. AMR, so it is important to diagnose AMR to prevent the chronically failing heart due to cardiac allograft vasculopathy. Yes, there's several points to discussion, but I will summarize that histopathologic AMR, immunopathologic AMR, we can understand these two concepts: histopathologic AMR, immunopathologic AMR, or both in the single patient. So we have to understand what's the histopathologic change of AMR and how we can diagnose immunopathologic AMR by histology. Histopathologic AMR is that mononuclear cell around the vessels and within the vessels. So small capillary and arterial level, there are lymphocytes within those areas. So it can be one marker of histopathologic AMR. And interstitial edema, it's not easy to tell it definitely, but it is described. And also, hemorrhagic necrosis and vascular thrombosis is a very advanced stage, so it's already too late to diagnose AMR. Immunopathologic AMR, we need to do C4D staining and CD68 staining. These two markers are useful markers for detect immunopathologic AMR. So these two immunostaining. But in Korea, as far as I know, the immunopathologic AMR and AMR even is not very much less common than Western countries. So I seldom see this antibody-mediated rejection in Korean population, and I hope it's we Koreans.
Professor, so could you finalize your comment in a minute? So time is over, and so please finalize your talk.
So this is last slide. So ACR, acute cellular rejection, is decreasing, and perioperative ischemic to acute lesion, and CD3, desmin, C4D, and allograft vasculopathy, AMR, and so on. And my slide is downloadable here. Thank you.